Unfortunately, in our generation, that trend is being carried on, that general medicine stands at the highest position. So I feel I just want it to be understood that all subjects have a beauty of their own, be it dermatology, be it ENT, be it ophthalmology, everything is important. And as a doctor, everybody should know a little bit about everything. See, the retina is such a structure. If you ask me in a funny way, I can tell it is just waiting to get detached. Okay, it's just such a sensitive structure. Whatever inflammation is there will spread to the retina, and the retina is going to be like waiting to get detached. Coming to posterior segment manifestations, this is really important because this is like it's easily seen in your indirect ophthalmoscopy, and it will give you a more accurate way of diagnosis. Tubercules, so choroid presence with tubercules, tuberculomas, serpiginous like choroiditis, and subretinal abscess. So in this, the first three would be the most important: choroidal tubercles, tuberculomas, and serpiginous like choroiditis. So choroidal tubercles, they are around 5 to 50 in number, and tuberculomas are a little bit bigger, but they are lesser in number. So this is how a tuberculoma appears. You can see like this caseous sort of nodule here, and choroidal tubercles are just much smaller yellow dots that are scattered in your choroid. This is how, for UG students, there is something I'm just explaining to you. There is something called indirect ophthalmoscopy. That is like a device that we fit on our head, and we use a lens to see the retina. That is how we are getting these images. Okay, this is from your indirect ophthalmoscopy. All right. So this is a scarred tuberculoma, guys. See, 12 months later, it has been undiagnosed. The patient is coming back. This is a scarred tuberculoma. Okay. So once the scarring has happened, since this retina is an extremely sensitive tissue, there is nothing to reverse it. Whatever scarring has happened will be there. Okay. Only once we detect it in our earlier stage and we give the treatment, only it will resolve. And there are some advanced tests that we can do called fluorescein angiography. So this fluorescein angiography is like you will be injecting the dye through the blood vessels. Depending upon the uptake, you can tell whether it is an active tuberculosis lesion or an already healed tuberculosis lesion, right? So there are many types. You can do a fluorescein angiography. You can do indocyanine green angiography. These tests are unfortunately only available in specialized eye hospitals and not normal medical colleges and your normal government hospitals. So that becomes a challenge. One more important differential diagnosis that you guys should keep in your mind is the difference between tubercular granulomas and sarcoid granulomas. So tubercular granulomas can be seen as large elevations on the choroid, and there will be a lot of fluid accumulation also. But in sarcoid granulomas, they are multiple. So I'll just show you this picture. See the first picture, we can see a lot of subretinal fluid accumulation. This is an OCT scan. Okay, this OCT scan is your optical coherence tomography. Okay, this optical coherence tomography is a very advanced type of scan in which you can see layers of the retina. It's non-invasive, and you can see all layers of the retina. Okay, so depending upon the number of granulomas that are there, depending upon number, depth of involvement, if the fluid is there or not, you can kind of tell what type of affliction it is. Okay, whether it is tubercular or sarcoid. At least superficially, you can tell. Now, the first three pictures on the upper part represent your tubercular granulomas. You can see that they are very golden. They have a very clear border. See these blood vessels that are going on top, they're vascularized. But you're talking about sarcoid, so there are little dull, quiet nodules, okay? They're not very, prominent compared to your tubercular counterparts. So this is from a recent article actually. These just show the size, shape, and location of granulomas. Just for an idea, I have put this. This is from Dr. Vishali Gupta's talk on urea. All the material that I have shown in my PPT, credit is not me. It is from various articles and various doctors that have posted. So I have just taken, amalgamated into one, and I'm just showing. So I do not take any credit for anything. Okay. So this is just one important table that, postgraduates in ophthalmology can refer to. As an undergraduate, this is too much actually. Then coming to serpiginous like tubercular choroiditis. So serpiginous means what? Shape like a snake. So it's a snaky pattern that you see in the choroid. So I'll just show you the picture, just short of time. So here, see, you can see the snake-like patterns in the choroid. Okay, so this is choroiditis. Now, if an ophthalmologist sees this, serpiginous-like and serpiginous, two types are there. We should think about autoimmune diseases. Okay, there are a lot of autoimmune diseases, Behçet's disease is there, right? So that we can think, and we can even think of tuberculosis in our endemic country. This is the same serpiginous choroiditis on your fundus fluorescein angiography. So one very characteristic feature that we have with this is the early hypofluorescence and the late hyperfluorescence. So it takes up the dye at a later stage. Okay, so the healing of these lesions may lead to scarring, and the best treatment is with oral corticosteroids. Serpiginous like tubercular choroiditis can be unilateral, there can be associated inflammation, and they are multifocal. But if you're talking about your autoimmune, they will be affecting both eyes. Okay, so that is one thing that you have to keep in mind. This is your subretinal abscess, guys. So everyone knows what an abscess is. It can be a collection of pus here, just beneath the retina. So this actually is treatable, and it may rarely rupture into the vitreous. That is actually a good thing. Okay. So there can be other associated retinal, vitritis, retinal hemorrhages, retinal detachments may be there. Okay. So that is about your subretinal abscess. Then this is your occlusive retinal vasculitis, right? So the blood vessels are involved, and there will be areas of capillary non-perfusion, and there can be periphlebitis also. Veins are more commonly affected. Okay. So that is it can be associated with bilateral vitritis. There can be retinal hemorrhages. There can be neovascularization, choroiditis patches, and neuroretinitis. So these are your perivascular choroiditis patches. Okay, just patches on the choroid. And this is how it appears on fundus fluorescein angiography. You can see areas of capillary non-perfusion here. Eales disease. Again, I think this is a very important question for third years, right? So what is Eales disease? It is a idiopathic, disease that is very commonly seen in young males. It can be very commonly seen in tuberculosis endemic countries in young males. So it is basically, it has periphlebitis, occlusion, and neovascularization. Okay, and they will be presenting with recurrent attacks of diminution of vision. So there is stage of inflammation, ischemia, neovascularization. Okay, so there will be stages of sequelae also that we have to be very aware about that can cause vitreous hemorrhage, tractional retinal detachment, epiretinal membrane, and neovascular glaucoma. So some of the complications that you should keep in mind is one is tractional retinal detachment. See, the retina is such a structure. If you ask me in a funny way, I can tell it is just waiting to get detached. Okay, it's just such a sensitive structure. Whatever inflammation is there will spread to the retina, and the retina is going to be like waiting to get detached. So that we should be keeping in mind, and because once it happens, then we have to refer them to vitreoretinal surgeon. So much headache. So better to keep the complications in mind and treat the disease as soon as possible, so I don't have to face all this. Again, we can get glaucoma, cataract because of the associated inflammation, rubeosis iridis because of the neovascularization. So it is just the iris, new blood vessels on iris, that is the rubeosis iridis. Okay, iris neovascularization, and lastly tractional retinal detachment. So why this tractional retinal detachment occurs? All this neovascularization causes a lot of pull on the retina, right? There is inflammation, there is fibrosis. It is just going to pull the retina, and I said the retina has been being just waiting to get pulled off, right? So that is why we have all these complications. One important treatment that we can do is your scatter photocoagulation of your ischemic retina. Okay, scatter photocoagulation can reduce the neovascularization, and it can protect the integrity of the retina. To reduce any associated inflammation, we can give you steroids. And if it is a very severe case of vitreous hemorrhage, then we have to take the patient to vitreoretinal surgeon, and they have to do something called a pars plana vitrectomy. Okay. Coming to your neuro-ophthalmic manifestations. So this develops as a result of direct infection or hypersensitivity. Direct infection is again very rare, right? It's mostly the hypersensitivity to the tubercular proteins that you can see this neuro-ophthalmic manifestations. So there can be optic nerve tubercles, like earlier I showed you those egg yolky lesions that appear on the retina, right? That can be near the optic nerve also, optic nerve tubercle. It can be a papillitis, that is associated inflammation of the optic nerve. It can be a papilledema, that is disc swelling. It can be an optic neuritis and retrobulbar neuritis. So these are some painful conditions in the eye. So this is the first picture will be showing papillitis. So papillitis we should be very, we have to keep in mind. See, this is some inflammation of the disc. Then retrobulbar neuritis. Okay, you can see the inflammation and optic neuritis. You can see some inflammation in the disc, hemorrhages, right? So these three should be kept in mind for your neuro-ophthalmic manifestations. Optic neuritis and retrobulbar neuritis are painful conditions. Okay, it's very painful. So only when you do the indirect ophthalmic examination of the retina and you see these conditions, then you can start with your differential diagnosis. Then lastly, we have your tubercular osteomyelitis of orbit. So just like ortho guys have the tubercular osteomyelitis of tibia, femur, even around the orbit, we can see, associated infection with your tubercular bacilli. So see in this contrast enhanced CT scan, you can see some enhancement, right? So that is nothing but the uptake. So there is a lot of abscess formation there. That is what you see here, okay, in your tubercular osteomyelitis of the orbit. And you can do the CB NAT of the pus aspirated from orbital cavity. Okay, this nucleic acid amplification test, you can do that and you can get your fast diagnosis, because we don't know. No. The child complains with the painful swelling of the orbit. We will always be thinking about bacterial causes in children, right? So we always have to send the pus for gram stain and CB NAT as well. There is something called paradoxical worsening of ocular tuberculosis. So this is a tricky situation which a lot of doctors encounter, ophthalmologists. So ocular tuberculosis. So the patient presents with all those manifestations that I've spoken about earlier, like serpiginous choroiditis or tuberculomas. And once we start our anti-tubercular therapy, that will or may cause worsening of the conditions. So when it causes, let's say I have a patient in my clinic that comes with these manifestations and I start him on anti-tubercular therapy after all the tests have come positive. And I call him after 1 week and I'm seeing worsening. So this protocol or this consensus tells me that I should not get worried, and it is a common condition, this paradoxical worsening. It is just an inflammatory reaction. That's it. It's nothing to be worried about. A lot of times, doctors may think that the therapy that they started is for the wrong microbe. But no, it's very common in your ocular tuberculosis. So, this worsening, initial worsening of the choroid manifestations is very common. And it's important that we do not discontinue the anti tubercular therapy. That is the main thing that I'm coming to. Once we start the ATT and you see this worsening, we should not get worried. We have to continue the full regimen. So that is why we have to, or we may give corticosteroids along with the anti-tubercular drugs. So that is the consensus for the concomitant use of steroids. It will prevent the inflammation and prevent these tricky situations in which there is flare-up. So this last few slides is just a very brief, overview about the tuberculosis drugs. I think everyone will be knowing about all this, your first line drugs and second line drugs. So I'll just brush upon it. Isoniazid, pyrazinamide, and streptomycin are your bactericidal drugs, or they kill the bacilli directly. And your ethambutol is your bacteriostatic drug. And then you have your second line injectables, fluoroquinolones, ethionamide, capreomycin, kanamycin, and so on, right? So these are your second lines. This is just your normal standard regimen that we use in our country with the intensive phase and continuation phase, with those adjusted measurements for children and adults based on the body weight, right? Then we have, again, it's the same thing. So we can group it into group 1, 2, 3, right? Group 1 is your first line oral anti-TBs, your HRZD. Group 2 is your injectable anti-TBs. Group 3 are your fluoroquinolones. Group 4, your second line anti-TB drugs. And then we should always be aware of those new anti-TB drugs also, delamanid, right? So that is also important to keep in mind, because nowadays with your extensively drug-resistant tuberculosis cases, we have to use that drug as well. So this slide was put up so that I could explain about your drug-related ocular toxicity. So ethambutol, right? So it's a double-edged sword. So you want to treat the infection, but at the same time, it's giving you optic neuritis. Okay, so that is important. We have to keep it as a side effect and monitor the dosage that the patient is taking. Optic neuritis can develop, and as a result, color vision abnormalities. And because of that, visual field defects can also develop. And toxicity occurs within 3 to 6 months of starting the anti-TB treatment. So we should have the patient, have a regular ophthalmology OPD checkup and evaluation for his color vision, fields, and all that, so that the drug toxicity we can monitor the progression. Rifampicin has orange-red discoloration of tears. I think that is the least dangerous among all. Okay. Then we have isoniazid, which also causes your optic neuritis, and it can also cause your Stevens-Johnson syndrome, that is involving the lids and conjunctiva. And then rifabutin in the end can cause anterior uveitis. So many of these drugs that you're actually using to cure the problem are being double-edged sword, and they are, in fact, they can aggravate the symptoms that the patient is already presenting with. We should be careful about that and monitor the dosage. So this is just a table that I have taken from the clinical ophthalmology book Kansky. This is just the uveitis. We have classified into infectious and non-infectious. It's a differential diagnosis table that we should keep in mind. It's important. So, this uveitis can be tuberculosis, syphilis, Lyme's disease, varicella, zoster. It can be non-infectious autoimmune diseases like, juvenile idiopathic arthritis. So kids that have this should be screened for uvea problems in the ophthalmology OPD. It can be Behçet's disease, which is very commonly seen in the Arab population. SLE, that is also quite commonly seen in India as well. Drug-induced multiple sclerosis. So a very advanced mode of diagnosing, because of your AI and all that, you have something called the COTS calculator. So COTS calculator uses an algorithm in which you can enter your patient's age, symptoms, the results of the tests, right? And this calculator will tell you whether that patient is a case of ocular tuberculosis or not. Okay. So it is an online, open access, cost effective, and automatically generated score. Okay. So this COTS calculator is from the Center of Ocular Tuberculosis Study Group, and it was, the guidelines were framed by the COTS Con group conference. So this is the oculartb.net. This is, you can actually find it. You just have to enter the patient details, country, clinical phenotype, endemicity of patient, the MAN2 results, the interferon gamma release assay result, and chest X-ray result. And from this, you can tell, the COTS calculator will tell you whether it's a short case of ocular tuberculosis or not. These are some of the diagnostic modalities. I think everyone will be knowing about sputum microscopy with your ZN staining, and then you can use your fluorescence stains like auramine, rhodamine, and all that. MAN2 chest X-ray. These are done in your government hospitals. Then culture media, one drawback, everyone knows, it takes weeks for us to grow tubercular bacilli. So I don't know. I personally, I hate culture media. It will take too long. We should, just stick to our CBNAT and PCR. Then we have so many other systems. We have radiometric, BACTEC 460 TB, MGIT, right? Back CT system. There are so many. There are so many modalities that can actually detect your tuberculosis. I thought it would be important to just mention about what happens in MAN2 test because it's so commonly performed. So it's like a screening test basically. You inject your tubercular protein, that is the purified protein derivative, 5 tuberculin units, okay? And you have to give it intradermally. And based upon the measurement, again, you can tell if it's more than 15 millimeters, it is positive. But some of the drawbacks that we should be aware of, in fact, drawbacks should be the first thing that you should be aware of in any test. So it is dose dependent. So that means if an inexperienced care provider injects a wrong amount of TU, then you will get a wrong diagnosis. Then it can cross-react with your BCG vaccination. Then it cannot distinguish from active and latent infection. So these few drawbacks are there which we should keep in mind. So coming to the ocular investigations that you can do, one is your optical coherence tomography, which I've already mentioned about, fundus fluorescein angiography, indocyanine green angiography, which is more commonly preferred because it is more better to visualize the choriocapillaries. And then we have your ultrasound biomicroscopy also, okay? So OCT is one of the best tests because you can see all the layers of the retina without any inhalation. So OCT, and ICG, indocyanine green angiography, are the two best. Just some pictures of culture bottles that I thought that I would put, because otherwise it's going to be incomplete if I just don't add it. Self-explanatory. I think everybody knows what Lowenstein-Jensen media is, right? So there are a lot of microbiology. It's quite interesting. Like, it's all colorful, and with your colorful indicators you can tell like what exactly is growing and all that. So I thought it was a necessary slide to be added. And then again, your genotypic and phenotypic methods, gene expert, fast plaque TB. Again, I am not the subject matter expert to go into these, but without microbiology and its diagnostic methods, clinicians don't stand anywhere. So, whichever subject you're practicing, we should never forget our roots. Microbiology, pathology, they are the foundations of medicine. So, without them, we're not able to diagnose anything. Then, yeah, this is just a table for gene expert, right? Just to give you an idea about what exactly happens in that machine. We just have to put the sample in the machine, and it will, amplify, and all the DNA segments and all that, and it'll give you like an answer. So yeah, again, it'll take 1 hour 45 minutes. Just put this diagram up. Again, I'm not an expert in what happens in Gene Expert, but it seems like a pretty reliable test. Then your IGRA, or interferon gamma release assay, is very important for your TB detection. So it is an in vitro assay, right? So it's very easily performed. It just measures the amount of interferon gamma that is released by your T cells that are sensitized to mycobacterial antigens. And two kits are commercially available, depending upon the company that they're manufactured in. One is your T-spot TB test and the quantiferon TB gold test. These are some of the recent advances, out of which I would like to talk about TrueLab Molbio. TrueLab Molbio is a kit that can be carried along with a doctor. Okay, so that is really good for resource limited settings, like especially in our villages, right? You wanna provide help, you wanna diagnose it fast. You don't have all those fancy stuff. You can take it, and the specimen actually survives in that temperature. It's not temperature dependent. On spot, you can take the sample and put it in those tubes that you see. So TrueLab Molbio is really good. Okay. Then the other ones, these are just some of the other things that I've already listed out before. And this is taken from Dr. Vishali Gupta's lecture on UVA. Okay. All credits go to her again. So it is from your Center for Ocular Tuberculosis Study, COTSCON color-coded algorithm. So ma'am has explained in that. I will just be conveying the message to you again. So this is a very logically formatted table which anyone can understand. See guys, green here means treatment should be provided spot. Okay. Yellow means think and wait. Red means no treatment should be provided. I'll just break it down for you. Suppose a patient from endemic country India, okay, endemic country India has purified protein derivative, that is your MAN2 test positive, IGRA test positive, chest X-ray suggestive of tuberculosis, then we should start the treatment. And he has anterior uveitis, then you should start the treatment. In non-endemic countries also, like let's say a patient in United States also has these symptoms, we can start the treatment. That is what the green circle says. But what does the red circle say? Red circle says that if a patient presents with anterior uveitis recurrent episodes in a non-endemic country, like let's say United States or UK, and their interferon gamma release assay is negative, that means we don't have to start the treatment. Okay, so it's a very easy table in which you can decide whether you want to start the treatment or not. It's quite easy. Now, coming to intermediate uveitis and pan uveitis. So again, intermediate uveitis does not warrant, see the circle is yellow, that means you don't need immediate treatment. You can wait and watch, right? So, but in green mandates spot treatment. You have to give the treatment immediately. So what is this? Pan uveitis. Pan uveitis means the whole uvea is involved, irrespective of whether the patient is from endemic area or non-endemic area. See, all these three are positive, and the patient is from endemic or non-endemic area. That means you need to give the treatment on spot. Okay, that is what it's very simple. It's a very useful color-coded algorithm. Then retinal vasculitis. So see, there are a lot of no's for this one. When do we start the treatment? Let's say the patient has something active retinal vasculitis. Okay, active retinal vasculitis we can diagnose from, like I said, fundus fluorescein angiography. By the uptake of that dye, you can tell whether the lesion is active or inactive. So see, active retinal vasculitis in endemic areas, and all these three tests are positive. You should start your anti-tubercular therapy immediately. But let's say an American man presents with this, okay, non-endemic country with all this positive with retinal vasculitis. No, TB will not be the first thing that you think about. So no, you shouldn't start treatment. You should wait and watch. Okay. So that's about my TB thing. There were a lot of things that I actually couldn't, break down and explain, thinking that it would become too much for the, talk, thinking that it was like a Instagram page for, all sorts of medicos with from undergrad and postgrad. So I thought I'll just stick to what people can get an understanding about.
Thank you, ma'am. It was really a great session. As you mentioned in the starting, the TB means people usually think of only lung infection, and TB of the eye is one of the least talked about topics.
Yeah.
And especially as undergraduates, we were really not aware of all these things. So it was a very comprehensive yet concise session. So thank you for this, ma'am.
Thank you. It's really nice. Thank you, Sneha, for patiently listening. I mean, I know that it was, for me itself, I felt like it was a very dry topic when I was making it. It was really difficult to get the information from all these sources because, see, first of all, like TB, it's so difficult. It is confined to pulmonology or medicine. No one thinks about other organs that are involved. I think even orthopedics people also, will be having the same thing to say. TB, osteomyelitis, like TB, people think about lungs. Other organs are also involved, so we should all, keep that in mind. And as doctors that are practicing in India, we should have extreme awareness about this condition because now it's up to our generation to make sure that we stop TB in all shapes and forms. So that's all I have to say. Another thing I have to say is that for undergraduate students, make sure that when you are studying a disease, know about all the organs that are affected. Because, like, let's say for ophthalmology, it's an interesting subject because there are so many systemic diseases that show your manifestation in the eye because as many ophthalmologists say, I'm inspired as a first year resident because eye is one structure that you can see directly with a light, that is your ophthalmoscope, without opening it. Any other structures, nerves in the body, your cranial nerves, you cannot see. But eye, if you put the dilating drops and you put your indirect ophthalmoscope or direct ophthalmoscope, it is one such structure of the body that you can see without any invasion. So you can see your optic nerve head. So that kind of fascinates me. And talking more about that, the retina or the eye as such is it speeds up your diagnosis because there are so many lesions that you can see in your eye that are associated with other systemic infections like bacterial endocarditis. You can see rod spots. There are so many affiliations that you can see for other systemic diseases with eye. So the diagnosis becomes simple for the clinician or whichever modality that doctor is in. So it's important to send the patient for your ophthalmology OPD for their screening so that we can examine the structures and make the diagnosis a speedy one. So that's the only thing I can say. And I hope this subject is well appreciated by our undergraduate students because unfortunately in our generation that trend is being carried on that general medicine stands at the highest position. So I feel I just want it to be understood that all subjects have a beauty of their own, be it dermatology, be it ENT, be it ophthalmology, everything is important. And as a doctor, everybody should know a little bit about everything. So those things are just some of the facts that I would like to convey to whoever is watching this.
True, ma'am. Very well said.
Okay. So, yeah,
Thank you.
thank you. Thank you, Sneha.